treatment? What if you don't have a topo-guided software available with you? And what if you only have a conventional treatment? This also seems to work. As long as you remain within the guidelines, even a conventional treatment can be done. Actually, one of the points in favor of the conventional treatment is, now when you do a topo-guided treatment, as I showed you in the earlier example, the maximum amount of ablation is over the apex of the cone, which is usually the thinnest part of the cornea as well. Whereas in a wavefront guided treatment, you're not removing the maximum amount of tissue from the thinnest part, but rather it is from the center of the cornea itself. So therefore, this could also be a way of saving tissue by just doing a little bit of conventional treatment. Though the challenge here is getting a repeatable wavefront in these irregular corneas. It's quite easy to get a good wavefront, a repeatable wavefront in a normal cornea, but getting it in a keratoconic cornea is quite challenging. I'll quickly run you through some examples where we've had this patient with 612. This was the earlier example with the profile which I showed you earlier. And post 6 months after the treatment, you could see a much more regularized anterior surface and with a lower residual power, with the BCVA also improving from 612 to 66. Again, another patient with a high amount of inferior-superior asymmetry, but a fairly centered cone. This patient, again, did quite well and had just a residual of 0.5 sphere and a diameter of cylinder and improved to 6.6. This was a patient, as you can see, had an extremely centered cone. And these patients tend to do extremely well with this kind of treatment. And you can see in 9 months post-op, it's almost as if his keratoconus is gone. This is one of the patients who did very well with this kind of treatment. And at 1 year later, he continues to remain 6.6 plano. So there was some initial controversy as to whether we should do this simultaneously or sequentially. And a large study by Kanellopoulos et al. Showed that the simultaneous treatment tends to be better. And some of the reasons which were given were that, of course, it reduces the patient's time away from work. But the simultaneous treatment, while we are doing a cross-linking, as you all know, there is an apoptosis of the keratocytes in the anterior 300 microns of the cornea. As a result of which, this could probably result in reduced haze when you're doing a PRK on these corneas. That could be one potential benefit. Again, if you're doing sequential, now you're removing a part of the cross-linked cornea, thereby minimizing the potential or adding to the risk of this cornea when you're removing some amount of the cross-linked. Now, again, when you're ablating in a cross-linked cornea, will your ablation rate be different from what you're doing in a normal cornea? Now, this is a stronger cornea, as a result of which, now whether the same amount of ablation which you do like in a normal cornea, whether it would give you the similar refractive result could be quite unpredictable. The safety and efficacy of this treatment has been proven now with 3-year outcomes showing. Let me highlight one point to you in this, where when you look at uncorrected and corrected distance visual acuity, the improvement in the uncorrected distance visual acuity over 3 years is quite impressive, more than 3 or 4 lines of visual acuity, whereas the CDVA tends to remain quite stable. The amount of improvement is not as impressive. This is again because these are all mild to moderate keratoconic patients where the best corrected visual acuity with spectacles or contact lenses is really not that compromised. We have seen similar results in our series as well when we have studied 71 eyes who have completed a minimum of 6 months follow-up, where again you see the uncorrected visual acuity improvement is quite impressive, whereas the BCVA tends to remain reasonably stable. And you can basically, the idea behind this procedure now is to give these patients a better quality of vision and a reasonable amount of spectacle independence. Couple of last points before I close is whether when you're removing the epithelium, how do you tackle it? Whether you want to remove it using a PTK mode in the laser or whether you want to do a manual debridement. Now we must remember that this topography is taken over the epithelium. And as Dr. Jagdish alluded to earlier, that the epithelium tends to be quite irregular in a keratoconic cornea, where it is thinnest over the apex and then you have thicker over the base of the cone. So now if you're removing an irregular amount of epithelium, which is a masking agent, what you have beneath it is a completely different topography from what you started off with. So possibly removing a uniform 50 microns of epithelium or so using a PTK mode could probably maintain the anterior corneal contour and therefore give rise to better refractive and visual outcomes. There was some initial discussion of whether to use mitomycin C in these procedures or not, as you're doing a cross-linking along with this treatment, whether that would take care of the haze itself. But then in collective experiences in multiple centers, we do see that these keratoconic patients do not behave exactly the way you would expect your regular PRK patients to behave, and they do have, say, a reasonable amount of haze. And most authors nowadays agree that we need to use mitomycin C. But despite all this study over the past decade, there are some unanswered questions. To what extent of ectasia can we correct using this procedure? What should be the attempted correction? How much ablation depth? What is the maximum that we can go to? We have a rule of 50 microns or 70% correction. All these are extremely arbitrary. And at the end of the day, we have so many different protocols of cross-linking available with us today. So what is the dosage of the cross-linking which needs to be administered along with this treatment? Probably further studies and over a period of years, even these questions will be answered. But as of today, it stands out to be a promising procedure which can be used in early keratoconus, giving the patients a certain satisfactory degree of spectacle independence. Thank you for your kind attention.
Thank you, Shreyas.
Yeah, so from 612, all patients.
So, being a thicker cornea, in the third case, the visual acuity didn't improve to a desired 6/6 with spectral correction, but with a higher, -2 with -4 spherical, the thinner cornea, you could achieve. Means, I don't just want to ask how this.
What I wanted to highlight in that example, maybe I didn't show it as clearly, is that some of these centered cones definitely do better.
Both of them are paracentral cones.
I'll probably, at the end of this, we'll discuss with the examples, and I think it'll be quite difficult to connect it. But when the cone is a little bit more decentered, even after a reasonable amount of regularization which we have achieved, oftentimes the BCVA doesn't necessarily improve to 6/6.
In which zone you are? Just paracentral or, say, around outside the 3 millimeter zone?
Yes. So when I say decenter, at least in the study which was published from NN, they had taken 2 millimeter as the criteria, with whether the cone was within the central 2 millimeter or not. But even if you take a 3 millimeter zone, if the cone is within the 3 millimeter zone, where you can achieve a better refraction, because after all we are basing this treatment also partly on our refraction and the amount of tissue available. So if we've got a better refraction, we do ultimately get a better postoperative result as well. But in a patient who has a more decentered cone, they do not do as well as the patients who have a centered cone.
That fourth patient was quite a decentered one, and he was lucky enough to get a 6/6.
Yes, so,
we'll discuss with the examples.
Yes, so we can discuss it over a cup of coffee outside, but let me tell you one thing, that this technique, even with Intex or something, you do come across where the refraction, subject to acceptance, which is just lower order aberration, can show up high, but that's more reliable, and that's where the clarity of vision improves. So I don't think we can correlate both of them together, but we surely can discuss it later on. I would invite Ritika to go ahead with her talk. Thank you.
Thank you, sir. I'd be taking you through a treatment modality which has become increasingly popular for patients of keratoconus. Intracorneal ring segments are basically open arc PMMA segments which were initially described for low to moderate myopia. However, excimer laser gave such outcomes that this technique was not really adopted for myopia. But the advantage that it offers